Okay. Hello, everyone. My name is Cyrena Gawuga. I'm the Director of Research for the Preparedness and Treatment Equity Coalition, and we're continuing our series of interviews for our this year's grantees. And I have another grantee with me here today who will introduce ourselves, and we'll talk a little bit about her research and what she plans to do with our funding.
Great. Thank you so much, Serena. It's really lovely to be here to talk about this grant. I'm very excited to meet you sort of in person, remote, but
Yeah.
it's good to see your face. So my name is Dawn Wiest. I am Director for Research and Evaluation at the Camden Coalition, based in Camden, New Jersey. We are an organization that's been working for nearly 20 years now on improving the lives, the health and well-being of people who live with complex health and social needs, whether they're in Camden, in South Jersey, anywhere in New Jersey or across the country. We are multidisciplinary. We started out working to develop a data-driven model that would address the needs of people who are cycling frequently through the hospital systems, yet finding no relief for the challenges they were facing. And we were very much at the forefront of this sort of cross-sector data sharing movement that has become very prominent, thankfully, in healthcare and social services. The purpose of which is to identify the trajectories of people who are not only cycling through healthcare systems, but across other systems and institutions. So we very deliberately developed models to improve transitions of care, not only across or within healthcare, but across multiple systems. And again, like I said, we've been doing this work for close to 20 years now. It's hard to believe. We're really strongly rooted in Camden, New Jersey, but have developed from that context to evolve our work throughout the state. And we have a National Center for Complex Health and Social Needs, which brings together complex care practitioners throughout the country to help to really understand the populations that we serve and to really improve health and social care services and the ecosystems of care that people, the communities are embedded in to, again, to improve the health and well-being of people who are struggling with complex health and social needs. And again, what that generally means is people who are not only perhaps suffering from multiple chronic medical conditions, but also maybe facing various forms of social risk, whether that's related to housing instability or food insecurity, and who also may be experiencing behavioral health complications as well.
So what brought you to this field of interest? Why, you said you've been working on this for over 20 years. Why this intersection between complex care needs and social care?
Sure thing. Just to clarify, I personally have not been working in this field
Oh,
for
okay,
that long.
Camden has
Yeah,
been
yeah, yeah.
okay.
Yeah, it's okay. Man, the Camden Coalition's been around for about that long.
Okay.
So my background is in sociology.
Hmm.
I come to this work with a very specific lens provided by sociology, which is to really think about anything we see happening in the life of an individual as being connected to broader social forces.
Yes.
Um, and so my background, my way into sociology was, like a lot of folks, like the trajectory is sort of winding, and I fell in love with data and research, especially research that has a social mission. So, in
Hmm.
other words, not not sort of driven by lofty academic ambitions, which are wonderful. And I really, I spent some time in academia and really do respect and appreciate it and loved it in some ways, especially the connection between research and teaching.
Hmm.
Um, but really felt more drawn to going out and looking for more applied positions. And so
Okay.
my background wasn't necessarily in health; it was actually in global social movements. And I've came upon the Camden Coalition, and so that the Camden Coalition, as I knew it, was a very data-driven organization
Hmm.
who really, emphasized using data analytics, research evaluation to improve care in communities. So that's what drew me into the work.
Okay. So that's very interesting that you say that because I think a lot of times that, that we may have people who are looking at this type of work and think that you have to have one path into it. I've spoken with students, high school students, college students who think that they have to be, you know, public health or like going through medicine to attack these kinds of problems. And, you've described your path and that there's very many ways of coming at problems. And that's one thing that at P-Tech we think is really important is that we have different backgrounds bringing their heads together to solve a problem. And that's exactly what you're talking about is kind of not coming from healthcare or public health, but having a different viewpoint on how to perhaps think about solving these very complex problems. So perhaps that kind of brings us into your grant that you brought to us. Can you tell us a little bit about that?
Sure thing.
Hmm.
Um, a little bit of background first in terms of like why the grant opportunity was so exciting.
Hmm.
The Camden Coalition was one of initially 32 sites across the country that helped the Centers for Medicare and Medicaid Innovations pilot the Accountable Health Communities model,
Oh,
which
okay. Yeah.
yeah, so that was that large scale initiative to test the hypothesis that addressing the social needs of individuals who have a lot of frequent contact with the hospital systems would help, um, especially the hospitalizations, ED, emergency department utilization that's driven by social need or social risk
Hmm.
factors,
Hmm.
that addressing those would have an impact on that sort of hospital utilization that we see. Um,
Yes.
so as I said, we were one of the sites that did screening for social needs, health related social needs
Okay.
in healthcare settings, and then provided navigation to community resources for those individuals who are eligible.
Hmm.
So we were part of that program for 5 years. And we had a lot of data. We still have a lot of data. We know that there was an evaluator for the national program who has been, evaluating the program, testing that hypothesis whether addressing those social needs would have an impact on hospital utilization. Um, I had so many more questions about our program specifically and about the ability of these kinds of programs to really make a difference or have an impact in communities.
Hmm.
So I was looking, or I shouldn't say, my team was looking to use the data, especially around social needs navigation, to understand, how successful these kind of programs can
Right.
be in
Hmm.
communities that may lack the resources necessary to truly address the needs that are identified through social needs screening. So this project that we developed is, on one hand, it's wants to capitalize on the data that we have
Hmm.
to ask specific questions about the program, but more than that, ask broader questions about the ways in which different structural factors may facilitate or impose barriers to the not only the ability to address the social needs that individuals are experiencing, but if those social needs are addressed, the extent to which that has an impact on health. And
Hmm.
in our case, like whether we do see, for example, people who have been screened and navigated to social resources in the community and who've also had extensive hospital utilization for, you know, potentially preventable reasons,
Hmm.
if we're able to have an impact on that and can see that impact not only in the individual level but at a community level. So as I mentioned, the County Coalition works with complex populations. So these are individuals that experience multiple chronic illnesses, and one of the most prominent chronic conditions that we see in our populations are cardiovascular. So this grant opportunity, when I saw it, we thought, wow, this is an amazing opportunity to ask very specific questions about our program, but also
Hmm.
broader questions about the extent to which communities can actually, have the resources to address those needs that we see, that individuals are screened for and that we see in the data.
Mhm.
So what we're doing, or what we've done at this point, is build a data set from the data that we have collected around our social screening
Mhm.
and navigation data, as well as connect that to our health data from the Camden Health Information Exchange, which is a data sharing platform where healthcare providers are inputting data um, about on patients who are frequent in hospitals. So it just
Mhm.
basically gives us a window into hospital utilization throughout the region. So it gives us information about diagnostics and frequency of hospital use, whether it's inpatient utilization or emergency department use. So combining those two data sets with community level data from the Census Bureau to give us indicators of what's, the demographic and socioeconomic profile of census tracts. And then
Mhm.
also through our partner, Find Help, we have now collected data on the social resources available within communities. So we're able to
Okay.
combine all of that data to ask questions. Number one, who is most at risk for extensive hospital utilization
Mhm.
based on not just individual characteristics, but also community level characteristics mentioned measured at the census tract level.
Okay. Mhm.
Um, uh, what how to what extent do factors such as structural racism come into play when we
Mhm.
see not only in terms of the prevalence of cardiovascular disease, the risk of cardiovascular disease, and social need, so social risk
Mhm.
factors that come into play. And then connected to that, when we look at the social needs navigation data, do we see differential outcomes for people based on where they live? And again, thinking about these deep historic factors related to race and socioeconomic disadvantage, to what extent do those come into play to either facilitate or impose challenges and barriers to people being able to get to the resources that they need, and then those
Mhm.
resources actually having an impact on their healthcare use trajectory. So that's the first part of the project.
Mhm.
The second part is, in my mind, one of the most important pieces of it is getting input from community stakeholders on what we're seeing in the data. So, when we look, for example, and see that, hey, we do see these patterns that are based on where people live, that folks in this census tract with this socioeconomic profile are having better outcomes than folks in this other census tract with a different socioeconomic profile.
Mhm.
How do we explain that from your perspective as community members? What do you see in this? How do you understand this? And then the second part of that is again related to this question of social needs screening and social needs navigation and resolution. What do we need in communities from in terms of like healthcare providers, social service providers? How can we do better at, first of all, having these conversations with people and understanding what's happening
Mhm.
in their lives, and then making that next step, which is to be able to support people as in addressing their needs. So that will be the second part of this, which is again focus groups of stakeholders, then a community forum around what we found in the data, and then ultimately to disseminate the learning from this. And part of it is, there's one piece of it which of course would be hopefully contributing to the academic literature, but more
Mhm.
importantly, being able to develop really concrete impactful policy recommendations for the next phase wherever we land in terms of this broader conversation around social determinants of health and social needs screening in healthcare settings.
Mhm.
Because one of our concerns is that there's so much attention paid to this for so many years now. You saw it everywhere: social determinants,
Mhm.
social needs screening. Everybody's doing it, but to what extent can we actually be successful in that? And what do we need to learn from the community to be successful in that sort of endeavor?
Mhm. I mean, this project was so exciting to me because it really speaks to a lot of the questions that I've had about the healthcare system, especially like you're saying, when there's more discussion of the social determinants of health, social needs, and screening. But I know that once it gets to the social care side, it's so much more difficult.
Mm.
So, I have training as a social worker. I've never practiced clinically, but I know a lot of clinical social workers, and often what they find is a lot of their, like you see, a lot of their chronic patients, frequent flyers, as they sometimes say, are people who really have very significant social needs, but the infrastructure for providing the social needs is very complicated and has a lot of holes in it. And so I think what your project is really trying to do is say not just collect data about the holes. PTech, we're always saying we don't want to just replicate collection of these inequities, but actually what can we do about filling these holes, and not just our thoughts about what filling those holes should be, but what does the community want? And I think definitely having a mixed methods project like you're doing is really saying that, yes, we're collecting this data, we're interested in, framing this problem with data, but ultimately we want this to do something. We want to make sure the community is a big part of that. And that's what I think we're really trying to do, is make sure that the projects that we're funding are always thinking about what the community's role is going to be, but also making sure that they're firmly grounded in data. And so that can, be challenging for people to put together, especially with how research funding tends to go. They want you to do one kind of thing. And so we wanted to make sure that we can provide funding for people to be free to expand their ideas. And so that's exactly what you said, you're doing. You have the data, you just need to, move forward with it in a way. Yeah. And so I personally have to say, this was one of I can say this now because you're not scoring, but this is one of my top ones, just because it going to answer a lot of questions that I have about how we're going to make the next step, and how we can support um, social service agencies and other groups that provide social care, because we're kind of pushing people and trying to load a system that already is, overloaded. And so we can say, how do we do this? And how do you want, as a community, how do you want us to do this? And so I think that's really exciting. And so when you talk about, um, you mentioned your kind of dissemination plan. And when you talk about sort of policy recommendations, what stakeholders are you speaking to? I know that you're rooted in New Jersey, particularly in Camden. Who do you want to see these recommendations when you finally, disseminate them?
That's a great question. So, there are a variety. I think first and foremost, it would be the people on the ground who are providing care. So whether it's healthcare, social care, and those are the people that come to mind first, because that's, often we think about, and I will say, and also the state of New Jersey, which we do have a good connection with. We do various projects with the state, so that's puts us in a good position to have their ear. Um, but I think that first group is really important also, because a lot of times, the policy recommendations are, trying to get at the heart, right? The heart, and
Hmm.
those are the people in positions of power who can, declare changes from above.
Right.
But the people on the ground also have to be part of that.
Hmm.
So I think in terms of the stakeholders that we're gathering for the focus groups, we're talking about community members, people of our own community advisory council, and community members, not only people who frequent the healthcare providers, but also the healthcare and social care providers themselves are important parts of those stakeholder groups. So policy recommendations for the state, and maybe we shouldn't call policy recommendations for the people who are providing care, but recommendations
Okay.
that are going to be coming from providers who are part of those groups, as well as other community members.
Mhm. Okay.
And we also have, through our national center, as I mentioned, we do have a national center
Mhm.
for complex health and social needs. That's going to be a great venue for disseminating what we learn.
Mhm.
So whether that's through a webinar or through toolkits or something like that.
Mhm. Mhm.
So we do have we have those three avenues, I'd say. So providers on the ground who are providing social or health care, policymakers at the state level, and then through our national center, we'll be able to reach, a national audience of practitioners and policymakers and others who have a vested interest in these types of initiatives.
Well, that's pretty amazing. I think that one thing that you point out that's often left out, the people who are often left out of these types of discussions are the people on the ground. And those are people who are doing the work and having policy recommendations like filtering down to them without recognizing the challenges that they may face in trying to implement those policy changes. It's really important to make sure that they are kind of central, like you're saying that they're an important part of it. Um, but I think it's fantastic that you already have like multiple levels of potential dissemination. And again, that's something that's really important to us, that knowledge not be locked behind a paywall or, locked within, ivory towers, but that people who all the, stakeholders in this endeavor that we call healthcare, social care, and the interface between them can see the information and have access to it and make the changes that need to be made to make sure that we have a more equitable healthcare, social care system. And perhaps at some point those won't be so separate.
Right,
That's kind of
right.
my hope, is that they won't
Yeah,
be so separate,
yeah.
because as long as there's a separation, there are people who are lost in the gap, you know.
That's a good point. Yeah,
So
right.
hopefully they won't be so separate. But I mean, this is at least a really major leap into trying to understand all of the different issues that may be going on that are keeping people from being as healthy as they can be. And I have to say, I love the census tract aspect of it, because you're like
Oh,
really
good.
getting down to the like nitty
Yeah.
gritty details. Because I will say, as a sort of a little bit of an aside, I live in Providence, Rhode Island,
Mm,
and so we're small, and so we often have like neighborhoods that are very different, butting up against each other. And so, that often people do analyses by zip codes,
mm,
and that's useless here, really. I remember I did a project when I was still in school and looking at census tracts in my neighborhood, and I think that that kind of study would be perfect here, because we have two census tracts that are, in my neighborhood, that are right next to each other, that are so different in terms
mm.
of socioeconomic status, in terms of racial and ethnic um, demographics, so many like in healthcare outcomes, so many things that are so different, but can be glossed over when you're looking at larger geographic distributions like
Yeah.
zip code. So that's a really important part. Again, something that's totally close to my heart, and again, something I really love about your project.
Oh,
Um,
you're getting,
so
I
that's
mean, it's so exciting to talk with you. It's sort of reinvigorate, how sometimes it's easy to get caught in the weeds of stuff, right? So,
yeah,
and data are never perfect. So,
right,
over the past month, like looking, as the data set has come together, like looking at it like, oh gosh, like if only we had this data or that data. Well, we have what we have.
right,
And it is, I mean, to your point, Serena, it's like, um, Camden, New Jersey, like people love to just like any place, right? People will cast all sorts of ideas of what they think it is as a place,
right.
and think of it as one place, but it's multiple places within a place. As you're saying, with Providence, you can have two neighborhoods that are very different. If you look like with such a, from so far away, you see one mass of people, but when you get closer, people are embedded in such smaller communities, and those
Hmm.
communities can be dramatically different. So I appreciate your enthusiasm about the project and agree 100% that getting down to the census tract level, is going to provide quite a bit more insight than those larger geographic groupings.
Yes. So we're about to wrap up. I know that you are a very busy person. Do you have any other final comments or things you'd like to add, either about your project or what you're hoping to see on you've actually said quite a bit, but about what you'd like to see, but any other final comments about the work that you're doing, or I don't know, health equity in general?
Sure thing. Well, I do want to say, one of the reasons that I was so excited about the opportunities because it's, for nonprofits who aren't like designated research institutes, for example, a nonprofit like ours, multidisciplinary. We have a small but very mighty data team.
Hmm.
It is kind of hard to get funding for this sort of
Hmm.
work. So in terms of equity, I think it's really. I mean, I think your organization and the way it's thinking about research and grantees and all that is really I think a really important step in that direction of equity, because I think about equity. One of the ways I've been thinking about it a lot recently in the past couple of years is around research and like
Yeah.
who gets research money and what sorts of projects are being funded, what sorts of
Hmm.
knowledge is being disseminated is very tied to who's getting the money, or the funding for the research. So, initiatives like yours is really important, I think, uh, for moving us in the right direction and thinking, more broadly about research and who can do research. So we're very, very excited about this opportunity.
Well, I mean, I can't say more than that. Thank you so much for, you know, applying. And I was really happy. Like I said, I can't be more enthusiastic about this type of project. But it's been really great talking to you and finding out more about your work. And so, again, thank you for joining me today. And we'll be looking forward to your results in the future.
Well, thank you so much. It was great to talk with you.
Okay.